The first case done at Baker Gordon in 1967, there was two, one by Reese and one by Salvador Castaneris. Castaneris popularized a skin muscle bleph. And this is what the procedure I learned in my residency. You took out fat, you took out skin, there was no lower lid support. And this was actually the first article ever published in PRS on cosmetic blepharoplasty in 1953. This gentleman, Dr. Flowers from Honolulu, really, I think, changed the way we thought about lower lid surgery, because he realized you really can't control shape unless you do something to support the lateral canthus. And so he at least in my mind, popularized the need for lateral canthoplasty in lower eyelid surgery. And this was actually debated for many, many years. He came in 1987, did this a coronal brow lift. He did anchor upper lid blepharoplasty, where he did supratarsal fixation. He did a skin muscle bleph, but he did drill hole canthopexy. And because of the drill hole canthopexy, it never got really it never got popularized in plastic surgery because of the morbidity of it, and she has a very nice postoperative result, but Tom said she was very swollen for about 4 months. So there's certainly more morbidity doing kind of a craniofacial procedure for cosmetic eyelid surgery. Then Glenn Jelks came along and said, you know, Flowers is right, but what are our technical options in canthopexy versus canthoplasty, you know, because tarsal strips horizontally shorten the lid. So he came up with, after doing cadaver dissections, understanding the anatomy of the inferior retinaculum, he demonstrated that you could approach the lateral retinaculum either through the upper lid or the lower lid, and he preferred the upper lid. So Glenn's big, I think, push in plastic surgery, as shown at this meeting, was not to do skin muscle blephs, because he felt if you divided the middle lamella, you set yourself up for lid retraction and a lot of the problems in terms of lid shape changes that occur in a transcutaneous blepharoplasty. So he preferred a transconjunctival approach to the fat, not to violate the middle lamella, not to deinnervate the orbicularis. He approached the retinaculum through the upper lid, and then he tended, in some patients, to do skin flaps versus skin pinch. He did this case in 2009. He did the corrugators through the upper lid. He did a lateral retinacular suspension through the upper lid. He did a skin pinch, and I thought it got a very, very nice result. The problem a lot of people had is getting the lateral retinaculum through the upper lid can be a bit tenuous, so Steve Fagan decided that maybe we could approach it through the lower lid like Flowers was doing, but not do drill hole canthopexy. So he came up with this operation. We did this case together in 2003. I did the endoscopic brow lift. Steve did the upper and lower eyelids and a retinacular canthopexy done through the lower lid, and that result. And so in terms of commonality and my observations done from the procedures done at this meeting, I think in general, canthopexys have replaced largely canthoplasties or tarsal strips because A, they're technically easier and they don't horizontally shorten the lid. And I think there's been a trend toward transconjunctival blepharoplasty rather than skin muscle flaps, so some people continue to use them.